All right. Thank you again for joining us today. My name is Michelle Lane, and I am the Senior Director for Community Health and Wellness here at North Kansas City Hospital, Veritas Health. Today, I am honored to have BJ with us today. He's a highly experienced pharmacist, and our guest speaker is going to discuss a really crucial topic. He's going to help us learn about how to enhance medication safety for older adults, reviewing the Beers criteria. This session is going to provide you valuable insights into how you can manage your medications more effectively and ensure the safety of adult population. BJ brings a wealth of knowledge and experience in this topic, and we're fortunate to have him share his insights with us today. So without further ado, help me welcome BJ.
All right, everyone. Thank you, Michelle, for that kind introduction. She says very experienced, but I am rather new and fresh out of pharmacy school, so I will, take that compliment very kindly, and let's go ahead and get started. So before we get started, just wanted to, kind of give you a roadmap or an outline of what we're going to be talking about today. So first, we're going to, review the purpose and history of the Beers criteria, identify commonly used medications that are on the Beers criteria, and then at the end, for fun, I kind of just wanted to apply the information to a patient case with a couple of questions at the end. Did want to provide one disclaimer. The material presented in the slides are for general information purposes only. It's not medical advice. If you do have any specific questions, you can always address those with your physician. All right, so now that that's out of the way, let's go ahead and get started. So what is the Beers criteria, and what does that even mean? It's a list of medications originally created by a physician, Dr. Mark Beers. It was published by the American Geriatric Society in 1991, and that's updated about every 3 to 5 years, with the most recent update being in 2023. So this list of medications is, guided towards patients that are over 65 years of age, and it's basically any medication that could have an adverse outcome. And the goal of creating this list by Dr. Mark Beers was to actually just reduce medication-related adverse events, so to try to prevent any unwanted side effects, which is a good thing. So how did Dr. Mark Beers originally develop these medication lists, and how do we do it today? We actually have a interprofessional expert panel that develops the medication list based off these 5 criteria. The panelists include physicians, pharmacists, nurse practitioners, registered nurses, as well as PhDs. And they use these criteria, which we'll go over in just a moment, with the first one being any medication considered potentially inappropriate in adults 65 years and older, medications potentially inappropriate in patients with certain diseases or syndromes, medications to be used with caution, potentially inappropriate drug-drug interactions, and finally, medications with dose adjustments based on renal function. Renal function, just another name for like your kidney health. So next sort of a big topic, especially that directly relates to the Beers criteria, is a term called polypharmacy. What this is, it's the practice of taking multiple medications to treat one or more health conditions. And generally, it's considered 5 or more medications. Some, depending on where you look, you'll see different numbers, but 5 or more is typically considered polypharmacy, with severe being 10 or more medications. So why do we care about this? And that's what this third bullet point is trying to speak to. Polypharmacy is actually associated with adverse outcomes, including mortality, falls, adverse drug reactions, increased length of hospital stays, and also increased risk of being readmitted to the hospital soon after being discharged. So obviously, each patient scenario is different. You have to weigh risk versus benefit for each medication and trying to limit where you can. So a little bit more statistics, just again showing the importance of why we care about polypharmacies. From 1999 to 2018, the prevalence of polypharmacy has been increasing. Most recently, in 2018, from where I pulled the statistics from, 59% of adults over 65 years old were taking 5 or more medications. We see this more often in women rather than men. And patients who take 5 to 9 medications have a 50% chance of experiencing an adverse drug reaction. Polypharmacy actually accounts for nearly 30% of hospital admissions. So again, kind of a very important topic to at least bring up and discuss with your physician. And so included this slide, I spoke about it, I guess, a little bit previously, the risk versus benefit. Each medication that's added to your med list, basically the benefit needs to outweigh the risk, right? Otherwise, that risk can lead to unwanted side effects, which can lead to admission. So ultimately, we want you on the correct medication for the correct reasonings, the right doses to help treat your conditions for whatever the medication is added for. But at the same time, we don't want to add a medication if it's just going to lead to unwanted outcomes. For instance, if we're treating hypertension or high blood pressure and we add on 2 or 3 different blood pressure medications and it's causing you to be really dizzy and you're having lots of falls, then we need to think of risk-benefit profile and see which medications we could potentially stop. That way you're not being as dizzy when you stand up and preventing those falls. So that's just a picture of a scale trying to show that. The next topic we need to discuss before diving into the Beers criteria, it seems kind of like a scary topic just because the word's kind of big, but pharmacokinetics is essentially what the body does to a drug. And we often refer to this as like the 4 major processes. So that would be absorption, distribution, metabolism, and excretion or elimination. I think those are all fairly self-explanatory with absorption. Maybe distribution's a little bit more difficult to grasp, so I included that definition there. Just the movement of drug to and from various tissues of the body. So, for instance, some drugs, they get into the body and they will be stored in like the fat tissue, call those lipophilic drugs. And then eventually they get distributed to the blood or to whatever organ or site that they're going to have their action. So that process is called distribution. So pharmacokinetic or PK changes are especially important in an aging population. This table's a little bit busy, but we'll work through it. So I have the PK parameters listed on the left-hand side. They're bolded, so we'll just start with absorption. Really, as you get older, there's minimal changes that occur to absorption, so we're not going to spend too much time on this one. However, if you do have any disease states, potentially like any gastric bypass or any sort of surgeries, you could see a pretty significant alteration in absorption of medications. But for your standard, I guess, like aging adult, you wouldn't necessarily see that. The next one being distribution. This one, we do see a pretty significant change for some drugs. And this is because you have a decreased volume of distribution for some drugs. However, it's increased for others. So they like to keep it very confusing and complicated. So it's increased for some drugs, decreased for others. This is due to the increase in body fat that we see with aging. So like I was telling you earlier, some drugs like to hang out in the fat tissue, while other drugs don't like to hang out in the fat tissue. So that's why we see an increase in some and a decrease in others. So I just listed some commonly affected drugs there. You have vancomycin, antibiotic, amiodarone, and diazepam. May have increased half-lives, whereas digoxin and lithium, for example, may have decreased half-lives. So half-lives is just another term for how long it hangs out in the body. The next PK parameter is metabolism. Metabolism, we generally think of the liver kind of being the workhorse here. It's responsible for, kind of breaking down those drugs and helping to speed along the process so they can be eliminated from the body. You have a little bit of decreased blood flow to the liver, and the liver just tends to not work as well as we get older, leading to increased, I guess it allows the drugs to hang out a little bit longer. So it's important for several drugs. I included those there as in lodipine, diltiazem, and ropinirole. So often, we can check your liver function with blood work, and we can sometimes reduce the doses of medications if appropriate based off of that. And then the final PK parameter I've listed there is elimination. Again, we kind of think of the kidneys being the workhorse here. They're responsible for, eliminating a lot of drugs through the urine. And we tend to see, just the kidneys decline in overall health as we get older. So this one's, very important for lots of drugs. And, in the hospital, we do a lot of dose adjustments based off of renal function. And again, that's another, like just general blood work that can be done, and we can do a calculation that helps us determine what your kidney function is. So drugs there are digoxin, gabapentin, and glipizide are just some examples of affected drugs. So just a quick question to sort of help summarize what we just talked about on the last table. As you get older, what may be potential reasons your healthcare provider might select an alternate drug or adjust the current dose of a medication? I'll pause for just a moment and, in case you're watching this on a recording later, and let you think about it, and then we'll go over it.
You have a lot of people putting D in the chat. I don't know. We'll see.
Great. So yes, everyone's putting D in the chat. So that would be the correct answer. As we talked, answer A is just really talking about metabolism and the liver's sort of decline as we get older. B is referring to, the drug distribution with our body fat increasing as we age. And then finally, C was talking about the kidney's ability to eliminate drugs. So you guys are correct. D, all the above. All right, so finally, medications on the Beers criteria. So rather than talking about each, individual drug, which would probably take us, hours, we're going to sort of group them into just this one big drug class, and then we'll talk about another fairly big drug class and more of a recent update to the Beers criteria. So first, I just wanted to start off with anticholinergic medications. Again, sort of the name can be daunting, but essentially it is just medications that block the action of acetylcholine in the central and peripheral nervous system. So acetylcholine, if you don't know, I guess like what it does, you can look at the image on the right, and those are some of the actions of if you block acetylcholine, what occurs in the body. So the anticholinergic medications I'll show you on the next slides actually have these as sort of their side effects. So we'll see, the skin, it causes like overheating, unable to sweat, causes constipation, dry mouth, blurred vision or dry eyes. And then sort of a big one, especially with Beer's criteria, is the effects they have on the brain, which include drowsiness, dizziness, confusion, even hallucinations. And then can cause rapid heart rate as well as urine retention. So, many commonly used medications are anticholinergic. They have, these side effects. So I'll show you just a brief table of common anticholinergics that are on the Beer's criteria. Doesn't necessarily, if you're on this medication and you're over 65 years old, like I said in the beginning, it doesn't mean you should stop it. Your physician, should be weighing the risk versus benefit of being on this medication versus not being on this medication. So the antidepressants that I have listed here, doxepin, amitriptyline, and paroxetine. Antihistamines, diphenhydramine, often, brand name Benadryl or hydroxyzine. So I included this Benadryl on here because it's kind of, one that catches people's eyes because it is an over-the-counter medication. So not necessarily one that people tend to associate with a whole bunch of bad side effects because, you can walk into any, drugstore, Walgreens, CVS, and probably buy a bottle of Benadryl. So wanted to list that there. And if your physician doesn't know that you take it, it'd probably be good to let them know that you are using it for whatever purpose. The next sort of drug category is incontinence or if you have overactive bladder, is another name for it. The drugs used are oxybutynin, tolterodine, solifenacin, and then the last one is antipsychotics. Olanzapine and quetiapine also have strong anticholinergic properties. All right, so moving on to the cardiovascular disease, the 2023 update of the Beer's criteria actually provided an update on several medications used to treat cardiovascular diseases. These medications include commonly used anticoagulants and antiplatelets. So I wanted to just briefly mention or discuss this since a lot of patients are on these medications and they just had a recent update with it. So the first medication we'll talk about is warfarin. It's kind of like one of the, I guess I'll say, older blood thinners. And so it's been out a long time, but the benefit of it is, it is relatively affordable. So oftentimes we are limited to this drug based off affordability issues. The Beer's criteria actually put out an update that they recommend avoiding use due to increased risk of bleeding for initial treatment of a type of atrial fibrillation or VTE, which is essentially just a blood clot. They also recommend avoiding use with SSRIs or selective serotonin reuptake inhibitors. It's an antidepressant due to increased risk of bleeding. So again, as I mentioned earlier, if you are on these medications, doesn't mean stop taking, just might be worth discussing with your physician and making sure you are on the correct medication that they want you to be on. The next blood thinner is rivaroxaban, also known as Xarelto. I actually put out an update that says avoid use, sort of the same thing with warfarin, avoid use due to increased risk of bleeding for initial treatment of non-valvular atrial fibrillation or VTE, blood clot. And this one actually has a dose reduction whenever creatinine clearance. Creatinine clearance is just a measure of your kidney function. So whenever we draw labs, we're able to calculate this creatinine clearance. And so if it's less than that number, it's an indicator that we need to reduce the dose because you're not eliminating that drug from the body as you normally would. The next blood thinner is apixaban, and they come out with a guidance statement saying, this one is okay whenever creatinine clearance is even less than 25 mils per minute. So even with patients with poor renal function, this one seems to be the go-to, the safe one, the safe option. And then sort of the final update that they had was with aspirin. They recommended avoiding initiation of aspirin for primary prevention of cardiovascular disease in older adults. So essentially, if you don't have any cardiac history and you're over 65 years old, they recommend avoiding initiation of this drug. So it might be a good discussion with your physician to see, I guess, what their recommendation is if you have any cardiovascular disease or any other indications to be on aspirin outside of cardiovascular. So sort of like my take on this, the role of a pharmacist, how can we help? This is just what I sort of came up with on my own. We can recommend alternative treatment options if a safer one does exist. We can review medication lists and screen for drug-drug interactions. Can help select over-the-counter medications for patients. So as I was mentioning earlier, if a patient comes into a Walgreens or CVS, always feel free to ask the pharmacist in the store to help you choose out the best medication for you. In the hospital, we're able to dose adjust medications as appropriate based off, your kidney function, liver function, whatever labs we get. We're also able to search for potential de-prescribing opportunities. So de-prescribing is, exactly what it sounds like. If you're on a medication, but you really don't need to be on that medication anymore, we can, reach out to your physician and see if it would be appropriate to stop that medication. And then lastly, just provide education to patients over their medications. Patients have a pivotal role in, determining their own health outcomes, and certainly being educated, knowing what medications you're taking, why you're taking them, the correct dose, the frequency, all of that good stuff is, very important, very important. So other clinical tools that are available out there, not as commonly used as the Beers criteria, but still just wanted to at least mention them in case you run across them. So stop-start criteria, again, it's sort of just another list of medications with geared towards patients over the age of 65, trying to prevent adverse outcomes. The EU7 PIM is just sort of the European take on the Beers criteria. So, reminder, the PIM stands for potentially inappropriate medication. So, that's just Europe's guidance on this. And then the ACB calculator, I've actually never heard of this one before I started making this presentation. So kind of an interesting one. And this just stands for anticholinergic burden calculator. And so I was playing around with it and just included one screenshot that I'll show you here. You're actually able to, type into this calculator and it kind of gives you a score of how anticholinergic a medication is. So I just selected two of the ones that we discussed earlier, the oxybutynin and paroxetine, and those were both listed as high risk. They have high anticholinergic properties. Another really interesting thing about this calculator is towards the bottom there where it says click here, it's kind of in blue. If you do click there, it takes you to a different page and they provide some recommendations or alternative therapies to use or to consider using to lower your anticholinergic burden. All right, so that sort of takes us to the end of what I was wanting to at least talk about in this short time together, and we'll go over a patient case. So we have a 78-year-old female with dementia, hypertension or high blood pressure, hyperlipidemia, urinary incontinence, and depression. They came into the clinic dizzy, and they've had 2 falls over the, since the last time they were seen in the office. The patient's medication list is listed there. They have aspirin, atorvastatin, oxybutynin, vitamin D, escitalopram, and lisinopril. And I guess I should have mentioned in the patient case, but all of their lab work and their blood pressure was within range. So this takes us to the 2 questions. First being, does this patient have polypharmacy?
Looking at my chat feature here. Okay, we have primarily yeses.
Yes, so good job. As we talked earlier, more than 5 or more medications is like the most well-accepted definition of polypharmacy. So this patient was taking 6. And then this takes us to our second question. How many PIMs or potentially inappropriate medications is this patient taking? 1, 2, 3, or 4?
There is a request to flip back. There you go.
I wondered if that was going to happen.
I have a mixed bag. I've got some 4s and I got some 3s.
Yeah, so we'll go ahead and go over this. So I was considering it to be 2 inappropriate or potentially inappropriate medications. So as we discussed, previously, oxybutynin is a strong anticholinergic medication that should be used in caution in our elderly population. This, kind of paired with the patient's dizziness and falls as, a potential reason to consider discontinuation of the medication, especially since, their blood pressure was okay, all their labs were okay. So it's like, what's causing these side effects since everything else is checking out? And then the other potential medication was aspirin. From the 2023 updates of the Beers criteria, it basically says, not everyone should be on aspirin if they don't have a reason to be on aspirin, especially as we get older. So, the patient didn't really have any history of cardiac disease, so like no no heart attack, no peripheral artery disease, so no vascular issues. So that's why I considered it two. Yeah, that's sort of those two questions and sort of my rationale behind why I had those as the correct answers. So sort of in summary, key takeaways, the Beers criteria is a clinical tool used by clinicians to help reduce adverse events, especially in our elderly population. Many commonly used medications are on this list. Just because it's on this list doesn't mean you can't use it. Again, kind of weighing that risk versus benefit of each medication, which is what your providers should be doing for all of their patients. So with that, kind of takes us to the end. And if you have any questions, I'd love to, try to answer them. Or if you, want to reach out to me via email, that's totally okay too.
I've got some thank yous. I've got some, that was helpful. So that's really great. That was a wealth of information. You taught me a couple things. So thank you so much, BJ, for sharing that information. I think that this is valuable insight, and especially for caregivers or for other healthcare providers to be mindful of these criteria. So thank you so much. I'm checking the chat here. Lots of thank yous.
It's always good.
Thank you so much for joining us today, everybody. And we'll send out a link with this recording to the email in which you signed up for the class. And so you'll have that and you can share it with others if you'd like to. It'll be converted into a YouTube link. And we thank you for joining us, and check out our classes at www.nkch.org/classes. Thanks, everybody. Have a good day.